you all, dear ladies and gentlemen. It has been inspiring to listen to all the fantastic presentations today. I'm glad we're here today, spending a whole day talking a bit about this important topic. And before I continue with my presentation, I would like to thank the Nordic Welfare Centre for organizing this event. I'm pleased to present a new report today, this one. It's called Dementia Prevention in the Nordics. The project and the report was an assignment from the Nordic Council of Ministers of Health and Social Affairs. The Nordic Welfare Centre has been managing the project and is an institution under the Nordic Council of Ministers. And the report is conducted during the last year. It's a close cooperation with the Norwegian National Centre for Aging and Health and a senior advisor, Pia Nevala Westman at the Nordic Welfare Centre. The mapping and the writing of the report has been undertaken by Aging and Health. Aging and Health is a national service for competence and research on age-related conditions and diseases. We have a comprehensive approach to our field with a broad understanding of aging and health, to promote health, to prevent illness, and providing conditions to live with illness. Do you want more information? Then you can visit our homepage. So the content for this presentation will be the background and aim of the report. It's a method and a model for descriptive approach, the main findings, and the conclusion and the recommendations. The aim of the report was to describe the policy and practice of dementia prevention and to get an overview about the dementia prevention work. And the main focus was on primary prevention. It's to prevent health impairment in healthy and vulnerable people before the disease progress begins. And the report seeks to answer, what does dementia prevention look like in the Nordic countries? What are the barriers and the opportunities? It's the role of the organizational aspects and the interaction between dementia prevention and existing public strategies. So, a brief look at the history. The development in the field of dementia prevention has exploded the last 10 to 15 years. This timeline shows the development and highlights some of the most impactful moments. Since 2009, several studies have shown that it's a falling incidence of dementia in the US and Europe. And these results have inspired researchers to investigate which factors have influenced the decline and if there are opportunities for prevention. This timeline also illustrates the development in research over time. The figure shows the number of hits and publications in PubMed during the year from 1990 to 2023. And it illustrates how the research and volume of scientific articles have increased remarkably in this period. In 2015, we have the first finger study. The first study in the world shows that lifestyle interventions can improve brain health and prevent dementia. The finger study has made significant and unique contributions to the field of dementia prevention. The Lancet Commission on Dementia Prevention, Intervention and Care published the first review in 2017 and presented 9 modifiable risk factors. In 2020, 12 factors of risk, and 2024, the 14 factors. And the new research shows that reducing the risk of dementia not only increases the number of years of good health, but also reduces the time the individuals with dementia spend in poor health. As we have heard from the World Health Organization earlier today, they declared dementia as a public health priority in 2019. In 2019, Director General of the World Health Organization commented to the new publication, "We need to do everything we can do to reduce our risk for dementia, and the scientific evidence gathered for these guidelines confirms what we have suspected for some time, that what is good for our heart is also good for our brain. We have all heard this term several times, but it's so important because it reminds us of having this holistic approach to dementia prevention. The knowledge base for this report is based on scientific evidence, grey literature, and reference material. It's a descriptive approach, and we had reference material with individual interviews for country-specific information, and we have a reference group. And the participants represented different sectors and levels in the Nordics. It was also a Nordic-Baltic roundtable meeting during this period. So, what does dementia prevention look like in the Nordic countries? We have heard about this earlier today, and each of the Nordic countries has its own approach to dementia prevention and have adopted a range of evidence-based measures against the risk of dementia. And all of them have robust healthcare systems. And for the details, I recommend you to read the report. But to sum up some of the key components they have in common, they all have national dementia plans, but there are some limitations. There are not that much focus on primary prevention, and it's not providing any clear recommendations on what to do to reduce the risk of dementia. And none has used knowledge or evidence for dementia risk reduction as the basis of a systematic prevention strategy. Legislation and regulation are effective measures at the structural level. It targets the risk profile of the entire population by changing social conditions and is characterized by unconsciousness behavioral changes. And we have some successful examples from the Nordics. It's the Nordic educational system. It's free, it's publicly funded and for all. And we have the regulation of smoking, and we have regulation of alcohol. So, to the actual health promotive and preventive measures for better brain health and to avoid dementia. They are carried out in practice at a national, at a regional, and a local level. At a national level, we have awareness campaigns, for example, the Hjernesund campaign in Denmark. We have the health promoting communities in Iceland and Finnish National Brain Health Program in Finland. These are just examples. Then we have public health guidelines and information, and that's our example with information at web pages. In Norway, we have helsenorge.no and Finger ABC, as we heard about earlier today. Preventive measures at a local level vary across, according to how the system is organized in each country. And there is a lot of local variation and initiatives. And the local level, we have the voluntary organizations and the NGOs, for example, dementia organizations, Alzheimer organizations. We have the municipalities and the healthcare regions, for example, healthy life centers in Norway, healthy care centers in Sweden. We have lifestyle intervention and secondary prevention, for example, learning centers and wellness centers. And we have age-friendly citizens and communities. So the examples and measures in the Nordics presented in this report are in line with the existing evidence and recommendations for dementia prevention. But due to a broad, comprehensive approach to dementia prevention, it has not been possible to provide a complete overview. But this report involves some area of improvement. There are some limitations of the evidence. More evidence is needed to determine the impact of dementia prevention in dementia incidents. And the existing, and the existing evidence is mainly results from a group level, which makes it difficult to recommend preventive measures at an individual level. And the research is mainly from the high-income countries and less from low-income countries. There seems also to be a gap between the existing evidence and practice in dementia prevention among people with intellectual disabilities in the Nordics. It is well known that this is a high-risk group for developing dementia. We need a greater focus on this group if they are to receive the same care as everyone else. And there need to be a greater awareness of lifestyle changes that might have preventive effect for this group. It's about education, it's about social inclusion, physical activity, and so on. So a new strategy is needed there too. So what are the barriers and the opportunities for the Nordic countries to include preventative perspectives on dementia? 4 key factors were identified. It was the lack of public knowledge. We need to make knowledge available for everyone. It's the challenge reaching out to different subgroups. We need to focus more on the high-risk groups, persons with intellectual disabilities, high-risk groups in municipalities, including minority groups, those with lower income levels, and people with low health literacy. We also have the organizational aspects. It's about financing and resources, and it's also about the healthcare system priorities. So the organizational aspects are central in supporting the implementation of dementia preventive measures. So, to sum up, the fact that there are common lifestyle factors connected to prevention and risk reduction for many diseases, it calls for a holistic approach to dementia prevention. And the Nordic countries need a long-term strategy, and it needs to be clearly integrated in the work on preventing other non-communicable diseases. There were also some areas of improvement in implementing measures. It was to increase awareness, both overall and in more vulnerable groups. And the implementation of practice should focus on easy to make healthy choices for all, promoting brain health and supporting cognitive functionality during the whole lifespan. It was also a recommendation to continue the collaboration. Such collaboration as the reference group in this project is a good example. This could enhance knowledge sharing and benefit practice and strategies in dementia prevention in the Nordics. Dementia is a key challenge globally, and it's very likely to be a central focus in the Nordics in the coming years. So we asked the experts from the Nordic countries the question, where will we stand in dementia prevention in 10 years? And here are some of the responses received. You don't even have to mention prevention. You don't have to mention disease, dementia, heart failure, or anything. I think that's the beauty of it. You're not focused on disease or the negative stages of life. You're trying to get people to focus on the positives. That's the essence of supportive societal structures for the prevention of dementia. Another one was that I think that solving the code for successful prevention measures for dementia is to avoid scaring people as well as to make prevention relevant and meaningful for the individual. We need to somehow make dementia prevention attractive, and we need new research so we can find more personalized and more effective strategies. The responses included many interesting reflections. And here I will focus on the last quote. It states, all abroad, the key to success in dementia prevention is that everyone is rowing in the same direction. So, in the end, I would like to thank all the contributors. My dedicated colleagues, Geir Selbæk, Anne Marie Mork Rokstad, Kari Midtbø Christiansen, the Nordic Welfare Centre, Helena Lonman, Pia Nevala Westman, and Michaela Lindemann. Thanks to all the experts and in the interviews and the reference group, representing the Nordic countries and the Baltic regions. And thank you all for your attention.
Thank you. Thank you so much. Now we'll give the stage to two commentators. First, Taru Koivisto, who is Deputy Director General at the Ministry of Social Affairs and Health, whom you met just earlier. The floor is yours.
Thank you so much for this opportunity to make comments on this important report. As we have heard during the morning session already, this is a mostly important issue and touching many of us personally. I think that's something which is very valuable to take up. I want to mention that, for example, my mother has a dementia, and it's very personal to me as well. So our future will be very much including the issues concerning the dementia. So, as I said, this report is comprehensive, and it's very important to have this kind of recommendations how to go further, because it's such an increasing importance in the future. And in all of Nordic countries and Baltic countries, this issue is increasing in difficulties. And this report shows very well that we have very much in common in Nordic countries, really, really much, as we had heard already during this morning. So, and at the same time, the chronic diseases are also increasing. Both of these issues have been taken up here, and also in the report, which is really, really good and good approach. So, but what is now good it has been taken up in the report that there is now more and more promising evidence about the possibilities of preventing memory disorders and dementia. So that's something which is good that we together consider how we can take this into account and make it happen, also take this as part of our activities. So it's really an opportunity also here to have a cooperation. This report offers our very good knowledge base, information, and takes up what are the possibilities, opportunities for prevention, and also practical examples from different countries. We in Nordic countries and Baltic countries have very much in common also our societies, culture, etc. So it's easy to share these examples also. Administrative structures sometimes are also very similar. So really excellent example of Nordic cooperation. Recommendations mostly included in the report are really worth to support. So I would like to take up some of the recommendations which from Finnish point of view are important. So of course it's important to have this common approach to NCDs and prevention of them, to use the broader approach to take these together, also as part of dementia prevention. So all countries have taken these issues also as part of the public health initiatives, which is also very wisely done. And it has been taken up also the issue of awareness. And already before the lunch break, it was very much taken up also the lack of awareness. So therefore, it's very good that the report takes this also. It's the general public which needs more information about dementia and also all the general risk factors. So it should be very strongly included in the healthy lifestyle counselling, taking up the obesity questions, tobacco, alcohol, etc. These risk factors and all awareness of their role in preventing both the chronic diseases and especially dementia. So very practical counselling services are needed, awareness campaigns, but I would like to take up the issue which was raised by Her Majesty Queen about and Pia from Denmark about the awareness of professionals. First, starting from the doctors, how to increase their awareness there, all the other health personnel, but not just them, but other professionals as well, which can have a role in increasing the awareness of these issues. So, for example, all the nutrition services, physical activity, schools, etc., all these professionals working there should have some knowledge about the prevention of diseases and also about the dementia. So I think that's something an opportunity which could be more taken into account and used. And politicians, not forget them. Awareness there as well about their decisions are very important. So then about in the report was mentioned the structures. I already mentioned in the panel discussion how important it is that we have cooperation with different sectors in prevention of diseases and also including prevention of dementia. And structures, how different sectors could work together, but also what's included in the report, the role of NGOs, civil society, and cooperation with these social and healthcare services, other sectors and public sector, but also NGOs are very important there. It's mentioned there in the report, and that's something which is also in Finland very strong experience, very good cooperation with them, so that's something very valuable. But also legislation, it's mentioned there in the report. So tobacco, alcohol, of course we discussed in the panel that how important these issues are, but also legislation which creates the opportunities for cooperation with the different actors. I mentioned in Finland we have this from 2010, the legislation on duties of municipalities and regions to promote well-being and health, so that there are that kind of duties as well for the different actors and to cooperate with other actors. So many kind of legislation pieces could be promoting the prevention of dementia. And then about how to take this approach. Primary prevention is not so strongly included in the thinking about the prevention of diseases. So that's something which we need really support, how to make this visible. So report is really good, basis for cooperation in the future. And really I'm looking forward to see that we use this opportunity in practical ways. So there are good examples of very practical implementation. Once again, I want to mention the finger activities. So we have good examples. Other countries have created some others. We have heard about Sweden's very good models, and so I think that's something which creates an opportunity for all us to learn from each other, to share not just study results, research results, but also good practices and good ways to work together. So just, perhaps I used a little bit too much time, but really want to thank you for this report and looking forward to good cooperation based on that. So I think in Nordic countries we are very practical, and I'm quite sure this creates an opportunity for us also to make this happen. Thank you.
Thank you. And Taru will come Taru will come back a little later. We have the second commentator here, and that is Michaela Prochazka from the Swedish counterpart Socialstyrelsen National Board of Health and Welfare.
Thank you very much. And thank you, Grete, for presenting such a comprehensive and important report and for the opportunity to review it. The report provides valuable insights into both the similarities and differences in how the Nordic countries approaches dementia care and prevention. It offers a broad understanding of each country's strategies and efforts and highlights the diversity yet in interconnected ways we address these crucial issues. Your work is an important contribution to our collective knowledge, and it will undoubtedly help us learn from each other to improve dementia care across the region. And I would like to offer some reflections from a Nordic perspective, particularly focusing on Sweden's policies and the responsibilities of our public authorities in this area. The report, Dementia Prevention in the Nordic Region, emphasizes that Sweden, like in its Nordic neighbors, places a strong emphasis on social welfare, public health, and equality. This regional focus is particularly evident in Sweden's approach to dementia prevention and brain health promotion, which reflects the report's finding on the importance of preventive measures. The Nordic countries, including Sweden, have adopted various evidence-based policies and practice that target modified risk factors for dementia. As outlined by the key studies like the Lancet Commission and the WHO guidelines. The report underscores the need for a holistic life course approach to dementia prevention, integrating these efforts with the prevention of other non-communicable diseases. Despite the progress made, the report identifies areas important areas for improvement, particularly in raising awareness and ensuring that healthy lifestyles and choices are accessible to all segments of the population. The robust healthcare system across the Nordic region prioritize prevention and well-being, aligning closely with the strategies and recommendations presented in this report. This comprehensive approach not only enhances brain health, but also strengthens the overall public health framework across the region. Sweden's national dementia strategy, developed with the key stakeholders like the Swedish Dementia Centre and local municipalities, exemplifies the collaborative approach typical of Nordic governance. The strategies focus on early detection and lifestyle interventions, such as those promoted by the finger model, as excellently presented by Professor Michaela, reflects similar preventive measures emphasized in Finland. Additionally, the use of specific coordinators to support the health promotion within municipalities showcase a decentralized approach that empowers local authorities, approach that resonates with the Nordic tradition of local governance and community-based health initiative, as also discussed in your report. The report also touches the upcoming Social Services Act in Sweden, set to be implemented in 2025, underscoring the regions and municipalities' commitment to legislative support for the health promotion and prevention. This proposal emphasizes supporting the health and functional capacity of all the adults, with, for example, healthy food and physical activity as key health-promoting measures. Preventing non-communicable diseases is a significant aspect of Sweden's public health strategy. Recognizing the shared risk factors between dementia and other chronic conditions, Sweden aims to address these issues collectively, as also detailed in this report. Public health and preventive care are deeply integrated in Sweden's healthcare system. The Swedish Dementia Centre, along with initiatives like the Finger ABC platform, are prime examples of Sweden's commitment to combining cognitive decline. The President, Wilhelmina Hoffman, there, will talk about it a little bit later. This program aims to educate the public and encourage lifestyle changes that can prevent or slow the progression of dementia. They are aligned with Sweden's broader public health goals, focusing on reducing chronic diseases and promoting healthy aging, as also noted in this report. Each Nordic country can draw valuable insights from the broad Nordic context to enhance its national work on dementia prevention. For instance, Sweden, like Norway, could further integrate dementia prevention into its broader public health strategies, ensuring that the focus on NCDs and lifestyle-related risk factors explicitly includes dementia. This might involve enhancing cross-sectoral collaboration between different levels of government and healthcare providers, akin to the integrating approaches seen in Norway and in Iceland. Sweden's approach aligns closely with the broader Nordic model, where national health authorities play a crucial role in setting the agenda for disease prevention and health promotion. However, we must also acknowledge the challenges we face. One major challenge is the gap between evidence and practice. Dementia prevention is a relatively new field with significant research emerging only in the past 10-15 years. It naturally takes time to translate these findings into effective public health strategies. The recent report by Alzheimer's Disease International highlights the need for a long-term strategy in this area. Additionally, reaching diverse subgroups within the population, such as immigrants, minority groups, and those with lower health literacy, remains a challenge. This underscores the need for targeted communication strategies and the adaptation of public health messages to effectively engage this varied audience, also mentioned in this report. Denmark's emphasis on research as a cornerstone for understanding and preventing dementia could inspire Sweden to strengthen the research initiatives. Other aspects worth highlighting, as discussed in this report, is Sweden's strong tradition of civil society involvement. Voluntary organizations and NGOs play a significant role in dementia prevention. For example, the Dementia Association in Sweden provides professional advice and organizes local activities. These organizations often receive public funding, reflecting the collaborative approach between the state and civil society in promoting public health. This model of cooperation is a hallmark of the Nordic welfare state, where the government, NGOs, and local communities work together to address public health challenges. The Icelandic model, which includes the comprehensive health promotion and community engagement, could be adapted in Sweden to create more inclusive and supportive environments for all the adults. Initiatives like Good to Grow Old in Iceland highlight the importance of community involvement and in promoting healthy aging and preventing dementia. And Elsa will also talk about a little bit more about that. I'm really curious about this project. In conclusion, Sweden's policies and initiatives in brain health dementia prevention are a testament to the broader Nordic commitment to public health, equality, and social welfare. The collaboration between national authorities, municipalities, and civil society organizations is a key strength that we can build on to address the growing public health challenges of dementia, as also emphasized in the great report. And I would like to extend my heartfelt thanks to you, Greta, and the expert team behind you. I hope that the Nordic examples of policy and practice presented in this report will serve as an inspiration for further efforts in dementia prevention and brain health promotion, both in the Baltics, but also through the Nordic region. Thank you.
Cases, we have a lineup of 5 examples of Nordic practices in dementia prevention and health promotion, and we're starting with Iceland and Elsa Fridfrinsdotter, whom you already have met. Welcome, Elsa.
Good afternoon, Minister and dear colleagues. Yep, that's me. In the past few decades, the Icelandic authorities have emphasized preventive measures for cardiovascular diseases, as we know them to be the main cause of premature death in the world, and we have made great success. In 25 years, the death rate from coronary heart diseases dropped by 80% among Icelandic men and women in the age of 25 to 74. It was estimated that a quarter of the reduction was due to improved drug treatment and operations for the disease, while 3/4 was due to changes in lifestyle. And I bring this up here because, as we know, many of the preventive measures for cardiovascular diseases are the same as for dementia. Healthy diet, to stay active, no smoking, minimize alcohol consumption, and so on. A key factor, though, in all this is not to appeal only to the individuals, but to the communities. The focus in Iceland has been on each community creating the conditions for individuals and groups to maintain their health. The paradigms of health-promoting communities have been used for this purpose. So now we are changing our focus a little bit from we have been talking about earlier today and talk about health-promoting communities and the links we have between these paradigms to preventing dementia. Health-promoting communities are related work is a result of ongoing fusion cooking. The underlying data comes from a variety of sources, not the least from WHO Healthy Cities, and I'm sure that many of you know that already. The population is divided into 4 age groups, and the emphasis on each health-promoting factor can be different between groups. Nevertheless, all these factors that are around the circle, alcohol and substance abuse and so on, as you can see, all of these factors apply to all ages. And as was mentioned here this morning, I really believe that sometimes we are too fixed on something that is considered as the problems of the elderly or something that is just related to the elderly, that we forgot to focus on the younger people, the middle-aged people and even children. Because of course we have to use different words when we talk about the prevention. I mean, it doesn't mean anything for maybe 16 or 20 years individuals if you are talking about preventing dementia. They just think, well, that's 50, 60 years away, so that's nothing to do with me. So I really think that we need to tailor our discussion to the age groups that we are talking to each time. And we have a solid foundation for systematic public work in Iceland, including the National Public Health Policy passed by the Parliament in 2021, which emphasizes collaboration across sectors and levels. And I should also stress our action plan for dementia prevention I mentioned this morning. The Health Promoting Community Steering Group is led by the Directorate of Health. And then we have 4 ministries participating in the steering groups, or representatives from 4 ministries: the Prime Minister's Office, Ministry of Health, Ministry of Social Affairs, and Ministry of Education and Culture. And we talked about education this morning and how much value that has in preventing dementia. The Association of Local Authorities also has a member in the group to ensure the collaboration between the 2 administrative levels. So this is a really high body. The main aim of the health promoting communities is support the communities to work in a systematic, data-driven, that's very important, data-driven way to create environments and conditions that promote healthy behavior and lifestyle, health and well-being for all. So that's the main aim. And it actually covers everything, all the prevention we can actually mention, and including dementia prevention. So both the local and the state authorities, they need to allocate funding and other resources to actions that really matters for well-being. And our first, our first health promoting community was established in 2013, the city of Reykjavik, our capital, and Mosfellsbær, a town in the vicinity of Reykjavik. And as you can see now, we have a little over 96% of the total population living in health-promoting communities. So that's extremely big. And as you can see, the blue areas, it's a very small part of the country that's not included. Health and well-being of people. Health and well-being of people and the planet is the result of complex interactions between individuals and their environments and conditions. So we have adopted the rainbow model of determinants of health to our situation in Iceland, and we include the priority SDGs. And as you can see, the rainbow model has 5 layers. So we start with the white one, the individual. So we have to focus on the differences in the population, the diversity of age, sex, hereditary factors, knowledge, attitudes, and so on. So we have to focus on the individual also, not just the community. The second one, the lifestyle of the individual, it's a fundamental part in health promotion and prevention, including dementia prevention. And as you can see, special emphasis is there put on nutrition. We all know that family and friends play a key role in mental health well-being and can prevent loneliness and social isolation. And that has been the topic of the day. And I really think that we need to focus on that not later than now, to try to minimize the loneliness and the isolation elderly people are experiencing, because they are in high risk then for dementia. The fourth layer, the red one, the availability of living, working and leisure conditions is of utmost importance and should be accessible to all. And speaking of sports and social life, I should mention that in Iceland, we, as some of you have experienced that have been in Iceland, we have outdoor swimming pool almost in every village. And even the smallest one I mentioned this morning with 53 residents, they have their own swimming pool, outdoor swimming pool. Small but beautiful, just at the sea level. So you should go there if you visit Iceland. And we know that these outdoor swimming pools, they are not just physical activity and outdoor activity. They're really good place for socialization, as we know that people just go there, swim, they get in, they have some coffee, meet friends, and so on. So we can combine all these preventive measures in one place, and I think that's the beauty of it. The policies and actions of national social governments are then that must contribute for the other parts of the rainbow to be in order. But having 63 municipalities of very different sizes and where the composition of the population is different, we have to tailor the actions to each community. As was mentioned here this morning, we know that one size doesn't fit all. So, what can we use to collect data? Public health indicators are a set of indicators that provide information or evidence about the health and well-being of the nation. Publication of regional public health indicators are part of providing an overview of public health in each residential area separately, compared to the country as a whole. So public health indicators are intended to facilitate healthcare authorities and municipalities, including then the health promoting communities, to analyze the situation of their own district, find strengths and challenges, and understand the need of the population so that it is possible to work in a targeted way to improve health and well-being. And so, I'll just open this up. No, sorry, I went to the volcano. That was not quite what I was going to do. So, we need to do that in a systematic way. So we start with number one, we need to gather data. So we need to use what we have, to determine health and well-being of the population, the strengths and challenges that the population is facing in each community. We use the public health indicators and other indicators for the data collection. And of course, there is a huge inside knowledge in each community just about the population and how the society works. And when we have gathered this information, as you know, we put forth the policy, the vision and the goals. We put forth an action plan and prioritize the actions. And it is extremely important to have measurable goals, because otherwise we don't know if we have made any progress. We implement and then we evaluate and see if we have made the progress that we hoped for, and then the circle starts again. So this is an ongoing process and systematic work. I'm concerned about the time. No? Okay. Few more seconds, then we go to the volcanic eruptions. As you know, we have now and my Icelandic colleague here, we were just talking about this morning that we believe this is the 9th eruptions since 2021, and probably the 5th with this year. We are not quite sure because this is always happening, so we just say, oh, once more. So, but that's not the way to think about this. We know that, or maybe you know that one night in November last, the whole population of Grindavik, they had to evacuate because of what was happening, and you see that on the right-hand side, what was happening in the town. So they had to evacuate, and it was actually a harsh reminder of what in the end matters for health and well-being, like safe home, work and income, schools and after-hours activities for children, mental health services, and not the least the importance of being part of social networks and community. And that's certainly valid for dementia prevention, to think about you as a part of a community and a social network. So, thank you.
LeVa-mottagningen. That's what I'm going to talk about. Tramline 11, that you see here, takes you all the way from the suburb Bergsjön in the northeast Gothenburg to all the way to the sun-kissed cliffs of Saltholmen in the western archipelago of Gothenburg, but only if you can buy a ticket. It will take you 60 minutes, 37 stops, and an additional 350,000 Swedish crowns in additional annual income, to gain an additional lifespan extension of 6 years. From Bergsjön to Saltholmen, the expected average lifespan increased by 6 years for men. But it's not just about living longer, health also improves. On average, there are 20 less sick days per year per person in the western part of Gothenburg compared to the northeastern part. My name is Kaisa, and I work at the LeVa clinic located at Angereds Hospital, which has a unique assignment to work with public health in the northeast area of Gothenburg. And today I'm here to talk about LeVa-mottagningen, LeVa, which in Swedish means to live. LeVa started as a pilot project 2021 and is now in full effect. And our aim is to reduce health inequalities and to support individuals to make healthy lifestyle choices, to promote health and prevent illness that leads to more pressure on the healthcare system, the society, and for the individual itself. And though we don't focus on preventing or treating dementia, we promote healthy lifestyle based on everyday behavior changes, and all we heard of today is that also helps to prevent dementia. So the problem statement, like a little background of LeVa. We know that many of the 100,000 residents of the northeast Gothenburg have poorer perceived health. Many smoke more and have unhealthy eating habits, have a more sedentary lifestyle, and fewer have a job to go to. It's also a fact that many of the residents in the northeast seek less health care than they actually need compared to other parts of the region and other parts of Gothenburg. However, it's a vibrant community full of social and cultural associations. So our challenges as health promoters is to build trust, lower barriers, and encourage people to seek our services. Because it's not uncommon that similar health interventions actually widens the gaps instead of decreasing them. And that becomes less effective, of course. This could be because those of us planning the health interventions have different background, different perspective, socioeconomics than the actual target group that we're there for. So therefore, it's crucial to include the target group in the planning process. Our mission with the LeVa clinic was to reach individuals with the poorest health. And I'm going to share an example of how we made ourselves more reachable for them. So what we do. There are two focus areas of the LeVa clinic. The hospital that you see there, the clinic work, and the other part is the outward collaboration, which is the dots here on the northeastern map. At the clinic, this is a short list because we do have a really long list of what we do. We offer health consultations with a new group of health promoter practitioners and with dietitians. This regarding lifestyle factors such as alcohol, tobacco, diet, and physical activity. And during the project time, we also did provide taking blood tests of blood lipid, blood sugar, and blood pressure. Unfortunately, during the budget, that's not something that we can do today. But we made ourselves available for our visitors that has poor digital skills. So it's not necessary to go on the national online booking service 1177 to book an appointment at LeVa. We have drop-in hours, so you could by the phone or in person come to the clinic and book your appointment for the following weeks. And this is to lower the barriers for the visitors. We also offer translators for non-Swedish speakers, free of charge, and it's a free clinic that requires no referral. Our other part is the outward collaboration, and we collaborate with the civil society, municipalities and non-governmental organizations, and many different meeting places for seniors, for example. In our outreach context, we do work with local health guides, whom are persons that has a cultural and lingual understanding from a different country, that work as bridge builders between us and the community. And they can cultivate trust in the community in a different way compared to us government employers. I want to share one example, because we've done many things in the outward collaboration at LeVa Clinic, but one example of how we co-create and also develop the intervention together with the community and health guides, and it's the autumn walks. To start a clinic during the pandemic wasn't easy. Everybody was at home and outdoors meetings were recommended. So we were thinking, how are we going to reach the community to say that we exist and you can come to us? So we thought, an easy way to increase physical activity is to give the advice to go out for a walk. That's something everybody can do. It's a low threshold option. That's what we thought. So we created open walking groups together with 14 health guides representing 10 different languages, and had open walking groups in the autumn with over 460 participants. And the participants were parent on parental leave, elderly, retired, and other people who were at home and available during the day. But the feedback that we continuously take in from the participants and the community emphasized the importance of actually walking in a group, because it turned out to be obstacles to go out and walk by themselves. Our idea was to inspire. You can go out and walk by yourself after you try this activity. It was crucial to walk in a group for the feeling of safety, security, and also social interactions. So it made us rethink the advice of saying, go out and walk by yourself. We created more walking groups the following autumn, and we spread the idea to our other collaborating parties. And it's those of us that working with public health, we need to go out and see where the people we serve and work for live, what are the needs, and really ask what matters to you. Here is the quote from the report that we have written about this autumn walk. that when we walk together, we feel safe and we can read signs and talk to the police if something happens and support each other, things that we didn't think of when we created the autumn walks. So was it profitable to open the lifestyle clinic? Well, health economic estimations from the National Board of Health and Welfare in Sweden suggest that starting a lifestyle clinic is cost effective if you go according to the guidelines. And also by taking the blood test as we did in the project time, we were able to find early detection of prevention and health problems, and that means less suffering for the individual, but also saving expenses for the healthcare system. It's crucial to continue to being accessible for the part of the population with the poorest health. And Agenda 2030 aims for leaving no one behind, perhaps not we're all going to the same tram station, but at least to the opportunity to have a good and healthy life. Thank you.
How come you started a lifestyle clinic?
Well, it started with the implementation of questionnaires about lifestyle factors that is implemented on the hospital. And many of the clinic workers said to us, but we need a place to refer the patients. We don't have time to take this in the meeting. So we applied for project money that was available at the Västra Götalandsregionen and started the project to see, could this be a help for the hospitals and for the community? And after that, it was implemented after 2 years project time.
So it was healthcare staff that came up with the idea?
Exactly. So that's the method of bringing in the ideas and suggestions from the healthcare staff, yeah.
Thank you.
Well, hello, my name is Annika Tetrolt and I represent the Wellbeing Services County of Ostrobothnia in Finland. I'm here to present the Seniors Advisory Services Unit we have recently developed, and I also present the process of creating a so-called finger network in Ostrobothnia. For those of you not familiar with the region, I'll show you a map here. Ostrobothnia consists of 14 municipalities on the west coast of Finland. The Wellbeing Services County is responsible for social care, healthcare, and rescue services. About 176,000 people live here. Of those, about 23% are over 65 in age, so about 41,000. The county is bilingual. About half have Swedish as their native language, including myself, and about 40% have Finnish as their native language. Our organization is completely bilingual. Our website is bilingual. We produce all our material, such as brochures, in Swedish and Finnish, and often English as well. And all employees use both Swedish and Finnish in their daily work. I also want to mention that Finland is in the middle of an extensive social and health care reform. The Wellbeing Services County as an organization is only 18 months old, and the Seniors Advisor Service in its current form has been in operation since the beginning of this year. So it's still a work in progress. So Seniors Advisor Services is a service we need to arrange, as stated by a 2012 law, the Act on Supporting the Functional Capacity of the Older Population and on Social and Health Services for Older Persons. Section 12 of the law says that local authorities must provide advice services that support the well-being, health, functional capacity, and independent living of the older population. So we set out to create a new operating model for Seniors Advisory Services. We set these objectives for that. We wanted to shift the focus from sick care to health care and preventive care. And we wanted to provide support for well-being, health, and functional capacity. And we wanted to be able to identify early the risk factors of developing chronic illness and to prevent common diseases associated with aging, such as dementia. We want to offer a low threshold support, no doctor's referral necessary, and we have easy access by phone directly to our senior advisors. We aim to offer lifestyle advice based on the 5 domains of the finger model for brain health. The 5 domains, as you already know, there are a healthy diet, physical activity, social activities, cognitive stimulation, and keeping a check on cardiovascular risk factors. And we also have the possibility to refer our clients to other services within healthcare as needed. And we want to enable continued at-home living, and our target population are seniors over 65 who do not have other regular healthcare services. Here's our senior advice services in a nutshell. We arrange group meetings for ages 70 and 80, where we inform about our services and the 5 domains of the finger model. We offer individual health and well-being checkups, and we offer lifestyle advice. The big blue box to the right lists the content of the health and well-being checkup. As you can see, it's quite extensive and includes the making of a well-being plan. So how do we work with the finger model in mind in our practice? As I've already mentioned, we are within easy reach by phone. The client finds out about our services, calls us, and makes an appointment. Before the visit, the client completes a form, digitally or a paper version, regarding lifestyle habits. She takes and notes blood pressure measurements at home for about 4 to 5 days, and she goes to the laboratory for basic tests, and also updates her list of medications. During the visit, we review the lifestyle questionnaire, lab results, blood pressure results, and the list of medications together with the client. We perform the CAIDE risk test, which is the cardiovascular risk factors for aging and dementia test. We identify possible risk factors for developing dementia and other illnesses. And we review the risk factors with the client, and we talk about the finger model. We discuss with the client what is the client's motivation and resources for change, what are the client's own goals and interests, are the group activities or other services that are out of interest outside of healthcare services. As necessary, we provide a referral within the healthcare system, for example, to mental health services, physical rehabilitation services, or a diabetic clinic, or dental services, just as examples. And we arrange an appointment for a visit with a doctor if that's needed. And we make a follow-up plan also as needed. And now on to the Ostrobothnia Finger Network. About a year ago, we set out to create a network in Ostrobothnia with the intent to strengthen the cooperation between the Wellbeing County, the municipalities, and the third sector associations, with a focus on preventive care for seniors and with the finger model as the basis. We wanted to map already existing services and groups for seniors with regards to the 5 domains of the finger model, and we wanted to gain a picture of what types of services still needed to be developed. So we started out exactly a year ago with an informative meeting for all stakeholders within these organizations. We continued with individual meetings with each municipality and third sector associations within each municipality. We summarized the collected data and conducted in real-life workshops in the northern, middle, and southern part of the county. We had a joint meeting where we presented conclusions and agreed on that we would continue this work and continue developing the network. So a summary of conclusions offers that there's a wide range of services already available. The challenge is for both staff and clients to find these services. We also agree that clients who need lifestyle changes can be identified by seniors, advisory services, and then referred to the appropriate groups and activities, and vice versa. And we also concluded that the cooperation and the communication between the Wellbeing County, the municipalities, and other stakeholders need to be improved, and the finger model actively implemented in daily work and activities. And as for the continuation, we're developing a shared digital service platform so we can more easily find the activities and groups that are out there already. We have organized finger information sessions for Wellbeing County staff. This is like internal, so that all the nurses and doctors are also aware of finger and know about it. We have an advanced practice nurse that has been engaged to coordinate the finger network, and we will continue meeting 2 to 3 times a year or as needed for updates and continued cooperation. We had a follow-up meeting in May where we, among others, had Christer Håkansson from Karolinska Institutet join us via Teams to tell us about his work and research. And another meeting is coming up in November. We have applied for further funding from the Ministry of Social Affairs and Health in order to develop the network further. Among other things, we want to improve our cooperation with occupational health services, and in January we will find out if our application was successful. This picture summarizes the network and the cooperation. In the upper left corner, we have the person finding himself in need of a lifestyle change. He either starts out independently, finding activities and groups, or he contacts us at Senior Advisory Services for participation in one of our group sessions or to make an appointment for an individual health checkup. We do the checkup and refer the client to the type of groups and activities that he himself finds interesting. We also make plans for a follow-up as needed. And lastly, a visual of our collaborative network within as well as outside our own organization. We work together with memory services and dementia nurses, physical rehabilitation services, social workers, physicians, laboratory staff, dietitians, dental care, and we also work together with pharmacies, congregation, municipalities, and third sector associations, and of course with family members of our clients. This image does not give a complete picture of our network, but does give an idea of the extent of our network. And this was my last page, but I also want to show brochures that we have developed. I have them both in Swedish and Finnish. I have extras if somebody's interested. Seniorrådgivning in Swedish, information about our services, and on the back side, phone numbers directly to our advisors. And we also developed lifestyle brochure based on the finger model, how to take care of yourself as you get older, with all the 5 domains. Here, short information, and on the back side, the client can set their own goals and a plan. Just an example of the material we have, and we're very much willing to share our material with anyone who's interested.
So first, Minister, ladies and gentlemen, I'm really happy to join you here today, and thank you, Nordic Welfare Centre, to arrange and host this very important conference today. And I'm also very inspired by all the very inspiring, excellent speakers before me. And I know that you heard a lot now about finger method, and Mia Kivi-Pelto described it so fantastic with the research behind all the findings. And what I'm going to speak about a little bit, it's how we join together, how to create some type of education in order to get this method, finger on feet or wings, to spread out to the society. And why do I say that? We all know that implementation is extremely difficult. And really research shows not only 15 years, it's 17.8 years before a new method is into the society. And if you have a strategy, it takes about 2 years or a little bit more. So what we are doing from the Swedish Dementia Centre, it's a national competence centre, it's founded by the government, and we are trying to be in the middle of authorities, academia, and all the people with dementia, and families, and people working in healthcare sector, and try to translate research into what you can use, how can you do it in practice. So what we have been doing since 2008, we have created a lot of education programs together with the National Board of Health and Welfare, and we started with the national guidelines. And it's not some type of Because when the national guidelines came out in 2010 for dementia, for healthcare and social care, it was a little booklet like this. How can you spread a booklet like this to assistant nurses, nurses all around Sweden? Well, we discussed that and we started a web-based education program 2010 together with National Board of Health and Welfare. We tried to make the guidelines practical. And then we started a contest, because how can you get people to be interested in what you're doing from the authorities, etc., if it's not some type of gain for you or your work? So we started that contest, and we had this Dementia ABC education program, and no one thought we could spread this around Sweden. How can you do that from your little center in Stockholm? But we succeeded, and we are so happy that we have a queen like Queen Silvia, because she was the prize, you know. Not the prize, but if a municipality and a region educated people in Dementia ABC, we made from the digital version of a map of Sweden, so we could see all the municipalities, all the regions, and you can see the arrows for each one doing the web-based education, performing the test, managed to know about the guidelines. They got an arrow upside. And so we could see all the countries started to do this contest because they wanted to meet Her Majesty, to have the prize. So it was a real contest between one municipality in the south of Sweden and one in the northern, and they called us and said, "Are we winning now?" No! So in the last day, it was like every politician in those communities started to be educated, trained about Dementia ABC, the national guidelines for dementia care. So what I'm showing here now is that web-based learning portal we have with more than 500,000 users, because we have now more than 15 free of charge web-based education programs. That could be a good portal also to spread information about finger method. So together with Mia Kivipelto, of course, we started to discuss how can we make a finger ABC education program. It must be translated so you understand what can you do, how can you do it. And it must prevent to be stigmatizing. It must be attractive in some way. So it's aimed at the general public, of course. It's 5 chapters, approximately 1 hour and 15 minutes. It's free of charge. And it was launched in June. And it was financed also by Her Majesty Queen Silvia Foundation for Research and Education. So, you know, she really is a good supporter of our work. So what is it in this education? It is called Finger ABC, and it's about the brain, of course, and heart. And you heard all about this. And it's a cooperation between the Finger Brain Health Institute and Swedish Dementia Centre. And the model is, you've seen this the whole day, you will dream about this, you will think about physical activities, you will start dancing courses in the weekend, of course, and you must check up all your values. So the finger model, and here you can see it's about health, food, physical activity, brain, physical activity, brain training, social activities, and check of the values. And we all know that each of those are good for our eating good, that's good. That's one thing. But if we do everything, it goes much faster and it's much better. So this is about the food, and this education program is all, it's animated pictures, but it is interviews with Mia Kivipelto, describing what she means, and it's with other professors describing the different parts here in the finger model. So it's very easy, I think, and it's very nicely animated. And you can see in the base here, it's like what you should eat every day, something from the base. Once or twice a week, you can have some fish or shellfish, etc. And chicken, eggs, perhaps little, not so often. And then, of course, very seldom, alcohol. We have been discussing this the whole day. Red meat, sugar, etc. So you have to see that. You can see that. And in this program, it's not like saying you cannot eat this, but you can decrease eating the bad stuff. And you can change something, like you change, for example, butter to oil or margarine, I think. And you can limit something. So this is what you can do when it comes to the nutrition part. And when it comes to activities, it's so different because you can be also in a wheelchair. What can you do then? You can have functional deficits. What can you do then? But what can you do each day? So you can check out that taking the stairs, you know that, not taking the elevator, and to stand up during work, for example, everything matters here. And then how you can do more physical activities. Of course, you go to the gym and you have this condition training, and then also you can train the strength on the top. So how can you do this in a good way? And about brain training, now it starts for you. It would be nice to meet again. Do you have a phone number? Yes, it's okay. Is it okay if I say it backwards, for example? So it must be a little bit of fun to learn and take in new knowledge about how you can live better. So this is a little bit about brain training, and I'm interested in this, that you can do, of course, a Sudoku, you can do the crosswords, but you know, also computer games can be very good for the brain. Not 9 hours of what we saw here, of course not, but how to stimulate the training of the brain. And it's also, if you are elderly and you perhaps are alone, you can have the computers, the small platforms, and you can have different types of like training there. We can help program those. And we know that people that can go to museums, for example, or find different special, what they are interested in, to find them there. And that's also good. And you need activity and you need to relax. And this is choir singing. And you know, about music, that's fantastic. Music, it's stimulating, and doing this together, to sing together, is both a social, you do it together, it's social, and it's also very good for the cognition, to singing in a choir. And people perhaps say, oh, I cannot sing. I think everyone can sing. It doesn't matter. But, you know, sounds and singing is something that I believe is so easy, and it creates a good atmosphere doing it together. We really have a lot of this in our day care facility at Silviahemmet, for example. So different activities, you have to be active and also to be social, and you need, of course, not always, you can be, to be alone is different to feel alone. And I also think there should be a law against loneliness, because being a physician, I can see the worst thing for health is feeling alone, really. So I think that all of us being cognitive healthy and in the social, we can do a lot of things to help people not feeling alone, of course. So together do things and gather, and we heard about different projects here. And I think in the civil society, we've been working with the civil society now. It can be arranged, different clubs, etc., so that you can meet and share interest. And here, I haven't had time to read the book, but it's wonderful to be here. And I think it mustn't always be that pressure, of course, of being one that report everything in the correct way, just being together. And of course, what's good, you heard that, this. And I love this symbol, the heart and the brain. And you also heard this quote, "It's never too early, but also never too late, changing lifestyle for better brain health." And it's very good to read things from the opposite side. And I would like to say that I've learned a lot today. I'm really grateful for that. 6 years ago, we wrote a book for people who were affected by dementia, together with people affected by dementia, how to keep up interest, etc. But now we are going to rewrite this. So I have my co-worker here, she listens to me now. So we are going to add also about finger, of course, in the new version. This has been out, 36,000 examples of this book has been out in the country. I will leave it to you. So if you are interested, it's free of charge. I have brochures about this. This is some pictures only, but there's moving pictures. And what I think is very nice now when Mia Kivipelto, the mother of all this, arrived, that we are going to translate this education to Finnish. Yes, yes. And also to English, because we think we need several activities to get these fantastic preventive methods out in the society. Thank you.
Well, thank you for inviting me, and thank you for all the inspiring presentations and dialogues during the day. I'm Tina, as told, and I come from the Dementia Corner, or Demenshjørnet as it's called in Danish. And I'm going to present a more practical approach to prevention dementia. Prevention in this context, more seen as delaying disease rather than preventing onset, of course. Oops. The Dementia Corner is a part of Aarhus municipality, and it is a political controlled organization. In Aarhus, dementia and preventing dementia is politically, has a politically high priority. 4,000 citizens in Aarhus live with dementia in different stages. And in different stages, the different needs, attentions, occurs. And the municipality, therefore, has a kind of target group divided organization with the possibility of specialization and targeting the interventions into the individual stages of the disease course. It has many benefits, but it also means we must have an ongoing focus on cohesion through transverse collaborations between departments and administrations. Some of the targeted interventions we have for people in the early stage of dementia is, of course, dementia, which I will get back to. And another one is Dementia Friendly City, which has 3 overall activities: to spread awareness and knowledge about dementia, to enter collaborations and partnerships with civil society, and offer dementia-friendly activities. We also have prevention consultants working with early tracing. In the later stages, we have a dementia team and day centers, and a dementia-specialized nursing home and a dementia-specialized day center as well. Before getting to the interventions in the Dementia Corner, I will share a few facts. Dementia Corner was established in 2014. There are 20 employees with different professional backgrounds, like occupational therapists, physiotherapists, nurses, psychologists, and social workers, among others. The target group is people under clinical assessment, people in the early stage of dementia, and people with mild cognitive impairment, and relatives. We provide 3 main interventions or services: training courses, counselling, and education for relatives. Approximately 2,500 persons use the services in the Dementia Corner every year. This year, until now, 100 persons have participated in our training courses. The focus today and the focus of my presentation is our training courses, which are evaluated and based on recognized methods. It involves 3 weekly sessions of approximately 3 hours duration over a period of 16 weeks. A training course includes physical training, cognitive training, and cognitive stimulation therapy. And the training is individually arranged and organized in groups to promote social connections and supportive relationships. The challenge is that some people are diagnosed too late to benefit from a course, unfortunately. We all know the benefits of the physical exercise. Numerous studies indicate a clear link between physical activity and a reduced risk of developing dementia. There is a moderate evidence suggesting that physical activity can enhance or stabilize cognitive function in the early stage of dementia. Aerobic exercise has shown the most significant impact on cognition. Additionally, it's recommended to engage the strength training twice a week and balance training regularly. The physical training in the Dementia Corner contains following: aerobic training, which involves 3 sessions of 10 minutes each on treadmills, bikes, or cross trainers. The aim here is to achieve 70% of maximum heart rate, so it's hard work. Strength training utilizing machines, free weights, resistant bands, or body weight. It challenges, balance, and incorporate functional exercises relevant to activities of daily living. Dual task training incorporates both physical and cognitive tasks, focusing on the process and strategies rather than outcomes. And then there's 1 weekly outdoor workout. These sessions emphasize connection with nature, mindfulness, and sensory activation. For the cognitive training, we used 3 different methods. The first one I will mention is robot-assisted cognitive training. It is 12 training programs, stimulate different brain functions, and support participants in finding strategies they also can use in their everyday life. The programs challenge many different ways of remembering and introduce many ways of solving a task. The participants interact with the robot through a tablet and use the tablet as well to solve tasks. The robot provides tasks, which means that the participants are more willing to challenge themselves. They blame the robot if something goes wrong and laugh at it. In this situation, the teacher is given a different role, where initiating conversations about the strategies between participants are a larger part. There is. The results clearly show that robot-assisted training has an impact on cognition without it being conclusive evidence. This is not based on scientific research. For a year, we have followed the results by using MoCA test. The results from our study show that it is impossible to increase concentration, build memory strategies, and that the strategies learned through the programs can be transferred to everyday life. Language and executive function in the MoCA test show that the participants make a lot of progress compared to the control group in areas that are otherwise difficult to enhance or stabilize. Another method is WISE Floor, an award-winning interactive learning floor developed in Denmark. It combines movement, play, and learning in an interactive experience on the floor. It includes more than 200 programs stimulating different brain functions in different ways, and in addition, we can easily make new programs ourselves. The activities are designed in such a way that they encourage cooperation and dialogues in relation to solving the tasks. In that way, it also supports training social skills and cooperation. The last thing I will mention is cognitive stimulation therapy, an evidence-based group approach that strengthens cognitive and social function as well as quality of life. It involves 2 weekly sessions of approximately 1 hour duration over a period of 7 weeks. The sessions follow the same general structure with an introduction and conclusion and a middle part activity where the theme varies from time to time. The unique thing about this method, I think, is that there is no true or false, right or wrong. It is entirely the participants' experiences, values, and opinions that are in focus. I will end my presentation by showing a small film about the Demenshjørnet. In the film, we will meet some employees and also a few participants, among them Pia, as you already had met. And listen to their experiences with the training. Please enjoy, and thank you for listening.
Jeg kan godt lide, at jeg ved, at jeg gør noget godt for mig selv og min sygdom. Det giver mig indhold. Det gør, at jeg har det godt med mig selv, både fysisk, og jeg ved, at jeg gør noget for min hjerne også. Det giver i hvert fald mig en eller anden tro på, at jeg kan gøre en lille smule for at forhale sygdommen.
Træningen her i Demenshjørnet, det vi kalder et mestringsforløb, er målrettet borgere med demens i tidlig fase. Det vil sige, mens man stadigvæk bor hjemme, hvor man begynder at mærke nogle tegn. Hverdagen går lidt i stykker, men man klarer stadigvæk sig selv. Et mestringsforløb er et forløb her hos os, hvor man både træner fysisk og man træner kognitivt.
Husk tallene, jeg siger, og indsæt dem i den rækkefølge, jeg har sat dem.
Det, som vi gerne vil have, at borgerne opnår ved en kognitiv træning, det er, at vi først og fremmest går ind og kigger på, hvad er det for nogle kognitive parametre, hvor de har deres styrker, frem for hvor de har deres svagheder. Og så er det der, hvor de har deres styrker, at vi sætter træningen ind og arbejder videre på at bevare dem og styrke dem.
Når jeg på et tidspunkt siger venter, så er det fordi, I skal skifte hånd.
Når nogle gamle sportsmænd og fodboldspillere og håndboldspillere, og så man tænker, man ikke lige kan få til at passe, så kan man jo godt mærke, at den reagerer ikke helt på samme måde, som den gjorde en gang, når man lige skulle krydse. Men man kommer man jo heldigvis bare til at smile og grine.
I en fysisk træning, der har vi primært fokus på, at de laver konditionstræning med moderat til høj intensitet. Det vil sige, at vi hjælper dem til at få pulsen op her. De får selvfølgelig en bedre kondition. De får også nogle kognitive redskaber i forhold til, at man får øget initiativ, øget tro på egen evne, det her med empowerment. Og det gør også, at man får bedre problemløsninger og bliver bedre til at indlære nye ting.
Morgenen og stop kan jeg tænke, det overgår ikke i dag. Men når jeg så er på vej ind, så glæder jeg mig til at komme ind og mødes med de der venner, jeg har fået. Og vi griner, og vi pjatter, og vi kan grine af, at vi ikke kan huske hinanden. Så kan vi bare have det så godt sammen.
Man får et fællesskab. Det gør, at jeg føler, at jeg kender nogen, der er ligesom mig. Fordi med de her folk hernede, der kan vi snakke om livet og døden. Og vi kan grine lidt af det, fordi det er os. Der er ikke nogen, der bliver fornærmet eller noget. Og det betyder rigtig meget.
That was a beautiful film. Thank you. So, thank you all for the presentations. And I now invite Anna Tenje on stage. She's actually our host because the Swedish government is co-organizing this conference. And for my part, I say goodbye and thank you. It's been a pleasure to be here with you and discuss today.
I think we should start by thanking you for guiding us through this extremely important and interesting day. You have done an extremely good job, so thank you, Cecilia.
Thank you.
And before I'm moving from my script, as I always do, I will make sure that I also thank the Nordic Welfare Centre for organizing and making this conference come true. As Cecilia said, this is under the umbrella for the Nordic Minister. We have the presidency in Sweden, and every minister have the possibility to choose what do you want to do during this year. And I said I would like to organize a conference, a Nordic conference concerning dementia. So here we are today, and I'm so thankful for all the presentations, the speakers, the panelists, and of course that you came here today to listen, to participate in the digital way or here in Stockholm and traveling here. I'm so proud that we did this, and I'm definitely inspired by the speakers today, by the stories, by the good ambassadors. And this is very important for me when it comes to doing the job now with the new strategy for dementia here in Sweden, but also make sure that all the knowledge that we have here in Sweden, from the scientists, from the professors, from the municipalities doing so good job many times. We have to spread the knowledge. We have to make sure, as we've said so many times today, that education continues on every single level, and that we cooperate on the local level, on the regional level, on the national level, and of course in between countries as well. So these types of meetings, I hope it is as interesting for you as it is for me. But first and foremost, I think this is the way for educate more people and make sure that the people working with the elderly in care facilities and so on get the knowledge by the ABC model from Dementia Centre, as Wilhelmina talked about, or in other ways as well, and make sure that the science that are making so much progress right now are really sipping down the knowledge. And in that way, perhaps the implementation won't take 15 years. It could go so much quicker because we have the knowledge, so we just have to use it. But if it is something I definitely take with me today, and it has been said so many times, and of course from Her Majesty herself in the beginning, it's never too late to start with prevention. And it's definitely never too early. So I'm looking forward, Mia, to hear from my children when they arrive home from school and talk to me about the high five model and how they want to change their lifestyle in order to be healthier and to get smarter as well. So thank you all for coming here today, and thank you for sharing all your important experiences. And we keep in touch, I think. Thank you.